So welcome to UCSF Urology's Grand Rounds. It is my pleasure to introduce Dr. Andrew Hung, Associate Professor of Urology at Cedars-Sinai Medical Center in Los Angeles. Dr. Hung completed his urology residency training at the University of Southern California, and he stayed on at USC to complete a fellowship in advanced laparoscopy and robotics. His groundbreaking research uses advanced data analytics and motion tracking to understand and improve surgical skill, with the goal of enhancing both training and patient outcomes. He has authored more than 200 peer-reviewed publications, received several NIH grants, and continues to be an internationally recognized leader in integrating technology, data science, and surgical education in urology. Through the dark web, I've also learned that he's an avid runner and can outpace all the residents at Cedars. We got some runners in our department, so we want to know what you're doing, what shoes you're wearing, what you're eating. But in the meantime, we're looking forward to your talk. So please, everyone, give me a virtual applause in welcoming Dr. Hung.
Thanks, Dr. Lindsay. I swear by Brooks Ghosts. Those are my go-to shoes, and I think the dark web may not be as trustworthy as you may think it is, but that's okay. Thank you for the invitation. It's really an honor to present to this illustrious group. And Cedars has a number of ties to UCSF, and we had your own Dr. Breyer as our visiting professor if it was last year or the year before, and it was really an honor to have him visit our campus. I'm going to share with you in the next hour or so our decades plus work on automating surgical skill assessment. And really the goals of this is that we know that surgeon performance is variable, patient outcomes are also variable, and we're hoping to lift the bottom line so that our patients can have more standardized outcomes. This is my one disclosure, and these are my active funding sources through the NCI. And so as an overview for the next hour, everybody knows what AI is, so I won't spend much time there. But I will talk briefly about the intersect of surgery and artificial intelligence. And then I'll go on to share with you our approaches to using AI to assess the quality of surgery, and then our most contemporary work on live surgical feedback, and then finally just a few take-home points. So everybody knows this. AI is the ability for machines to independently replicate what humans do with human cognition. And machine learning is a subset of AI where these algorithms, computer algorithms, can parse through data, learn from it, and then apply what it's learned to make informed decisions. And deep learning is yet a subset of that, where these models are yet more sophisticated, inspired by the interconnecting neurons of the human brain to make even more effective decision making. So what is surgical AI, or some call it surgical data science? It's a small, relatively niche field of using AI technologies to assist and enhance surgeon performance. And luckily, it doesn't say quite yet replace the surgeon. This is in graphical form. If you asked GPT what that looks like, luckily there is another human in the picture other than the patient. And what I see is lots of data, whether it's before surgery, during, or after. And I'll argue that a lot of this data is left on the table, meaning that it's not used to its fullest potential to help us make decisions before surgery, during surgery, and even afterwards. And so, the hopes are that we can harness some of AI's abilities for pattern recognition and more so that we can make better decisions all around. All right, so in the last, I'd say 12, 13 years that I've been in practice, I am a urologist. I specialize in prostate and kidney cancers, but my, I guess, part-time job is also as a researcher, and been fortunate that we do have $10 million of active funding in this very specific space, which 10 years ago or 10 plus years ago was not really a field at all. And what we have done is we've looked at how we can size up surgeons in three different ways. And the first of which I'll share is through kinematics. And this is essentially a fancy word for motion tracking. So this started about a decade ago. This was a partnership that I had with Intuitive Surgical. I was its very first clinical partner, putting these black boxes in the operating room where we recorded live surgical video. So it was the very first time this sort of device was deployed in the live operating room setting, where we recorded video, but synchronized to the video, we are also collecting systems data directly from the robot, such as the instrument kinematics or motion tracking in 3D space, but also system events such as energy use, camera move, and so forth. And it was derived from these that this data that we derived what we've coined as automated performance metrics. They've now rebranded it to something else, but these are summary metrics of what's going on with the instruments, with the camera. What is the surgeon doing effectively? The simplest examples of this are the movement of the moving time of the instruments, the velocity, acceleration, deceleration, angulations of the wristed instruments, and so forth. And this was our first publication using these metrics and in the live environment. This is for the radical prostatectomy. And this is simply an illustrative example of what this data looked like. It was refreshed at 30 hertz. The red is the tip of the right hand, the green is the left hand, the black is the tip of the endoscope. And these are two different surgeons performing the exact same step of the prostatectomy. And as you see it, they look completely different. So this was our first foray into this space. But then therein lies the challenge. We know what it looks like, but we don't know what movements actually are important and what are not. And so we look to machine learning as a way of parsing out the data. 30 hertz for a 2 to 4 hour operation. You can imagine the volume of data that comes from that. So we look to machine learning as the tool to enable us to parse through all this data. This was around 2017 or so, certainly before ChatGPT and the way we know AI today, where it's in everyone's smart devices. And we published this in JAMA Surgery, where we took 70 odd cases of the radical prostatectomy. And we had recorded the data in the operating room, and we tagged each set of these metrics with a clinical label. And early on in our experience, we didn't have much of long-term data, but we did have how long patients stayed in the hospital for. The majority of patients stayed in the hospital for 1 or 2 days. This is before the time of same-day discharges. Rarely patients stayed for more than 2 days. We trained the model with these automated metrics and with these clinical labels. And once he had a trained model, we wanted to predict its outcome. And so now you have a brand new case, just finished it in the operating room. We have the set of automated performance metrics, plug it into the model, and we wanted to predict how long was this patient going to stay in the hospital for. And to our surprise, it was accurate 85% of the time, which was encouraging. Now, long term, nobody really cares how long they stayed in the hospital for, but this was a proof of concept. This was the concept that could you record data from the time of surgery to predict something that happens to patients sometime in the future? And it was certainly encouraging enough that we continued this journey. As an aside, I dug this out from the volumes of our prior research. We've done a lot of original work. This may be interesting, hopefully, particularly to the residents. So I shared with you how we can study how a surgeon's essentially hands are performing during an operation. But what if you could literally look into the eyes of a surgeon and get a sense of, how stressed they are or how much they're concentrating? So there is something called task-evoked pupillary response. This is a measure of not the absolute dilation of the pupils, but actually how they change over time in response to performing different activities. And the person I partnered with for this was Sandy Marshall, and her company. The typical client of her company were aerospace engineers and essentially every large major car manufacturer. So as they're designing these fighter jets or brand new GPS systems for cars, they wanted to measure how much cognitive workload was applied to the fighter pilot or the driver so that they can fly the plane or drive the car without, with all the bells and whistles, in the cockpit and so forth. And so from this pupillary response data, you can actually put it down into what we call an index of cognitive activity. So a zero meaning that the person's basically not alive, and a one is you're maximally stressed out or super concentrating. And so this is one of the papers that we published. This is a number of years ago, but this was in the dry lab. So we had 26 participants. We had our medical students who were the novices. We had our residents who were the intermediates, and we had our expert surgeons perform a variety of tasks. And this was our most complex task at the time. This was very expensive. These were clementines from, I think, Trader Joe's, where we had the participants pop off the lid, almost like a pumpkin, and then wedge out one of these orange pieces of fruit, causing minimal blood loss or orange juice. This was our advanced dissection model. And what we found, at least in terms of the automated performance metrics, these measures of efficiency that I just shared with you, not surprisingly, the experienced surgeons were more efficient, right, in all regards. And we also, not surprisingly, found that the experts exhibited less cognitive workload compared to the intermediates and novices. And that was across all the various exercise types. Okay. But this was the more interesting part to all of this. We found that if you looked at the experts, so compared to the novices and intermediates, they had overall a lower level of cognitive activity as they completed these tests. But if you just looked at the experts and relative to themselves, that at certain areas of time when their ICAs or cognitive activity did go up during different parts of the operation, what happened with their hands and camera, all of their instruments, dominant hand, non-dominant hand, the camera, everything slowed down. In contrast, our medical students and our residents, when they were stressed or concentrating, everything sped up. And the only way to really explain this is perhaps that for the intermediates and novices, what they exhibited was the fight or flight response. If you have a tiger or a cougar chasing after you, you're going to run faster. But the learned response is for the expert surgeons that they have learned that when they need to concentrate, when they are a little bit stressed, that they've never been rewarded by moving their hands faster, but in fact, slowing down, catching your breath, getting a sense of what to do, composing oneself, and then taking action is the way to do it. And that's what we have effectively seen as this is what we saw in our study. All right, so going back to these three approaches for sizing up how surgeons perform, I'm next going to share with you technical skills. This is the engagement with tissue. So the difference between kinematics is what the hands are and the instruments are doing in 3D space. It almost doesn't matter what happens to the tissue. But for technical skills, it's the actual tool tissue interaction, and I'll give you some specifics in a second here. So we wanted to up our game also. So before we're trying to predict when patients were going to get discharged from the hospital, but here we wanted to do a survival analysis. We wanted to predict time to something happening, and also we wanted to find something that was a bit more meaningful. As many of you know, there is a trifecta of outcomes. And urinary continence had historically been one where this is pre the time of retio sparing and hood preservation and so forth. That urinary leakage was a real problem. And our thoughts were that there are patient factors as well as surgeon factors that may contribute to this outcome. Patient factors, we have a standardized set of 15 characteristics, such as the uh, age of the patient, their body mass index, and then your PSA, clinical staging, Gleason score, all that sort of thing for prostate cancer. Now, surgeon factor, in the past, we had only one thing, and that was the experience of the surgeon. So self-reported number of cases, and that was it. And for the longest time, even today, if you have a brand new patient walking into to your consultation room, and they ask you, well, you know, how many of these have you done, right? That has been that gross measure of how well a surgeon performs, and we wanted to change that. So for surgeon factor, the first bit we used was these automated performance metrics. Again, that's the first concept I shared with you. But the second is this is the first time we brought in technical skills. Again, this is how a surgeon engages with tissue. There's here you see one for suturing. There's a parallel one that we have developed for tissue dissection. But for suturing, it's how do you hold the needle? How does the needle enter the tissue? How do you drive the needle through the tissue? How well are the stitches placed? How well does the wound come together, and even knot tying? And at this time, this was all manually done. But to our pleasant surprise, again, this is our bid to predict time to urinary continence recovery using this survival analysis machine learning model. That if you use just the automated performance metrics, we hit a ceiling of about AUCs in the 60s. And we were stuck there for many years. But when we adopted technical skills, this was the first time in this particular paper that we did, we got our AUC into the 70s. Again, this is the ability to predict when these patients were going to recover function. And then finally, if you had everything we knew about the patient and the surgeon, so the patient factors plus the automated performance metrics or kinematics plus the technical skills, we got our predictive accuracy up into the 80s. Now, as many of you know, machine learning models are great not only for the prediction, but also for feature ranking or identifying from the pool of various features or data sources which were the most useful in correctly predicting the outcome. And what we found was that age was the only patient factor that helped us correctly predict when patients were going to recover urinary continence. And surprising to us, the purple, which were all the technical skills, RACE was an acronym for our tool, but all three out of the top five were these metrics on suturing. Okay. Immediately, the smart folks in this room, which is probably everybody, would say, well, what does suturing have to do with urinary continence recovery? Well, look, that's a regular procedure for me to do. I don't think that suturing directly is a cause effect to continence recovery. However, at least in this case, we think suturing is a great measure of surgeon performance in general. And we know that surgeon performance in general will impact continence recovery. And so that's your relationship. So importantly, I want to point out this is not about a cause and effect, but this is certainly an association. Nonetheless, it pointed us to the fact that suturing technical skills may be a fantastic way of assessing the quality of surgery or one facet of surgery. And so I wanted to automate that process simply because it's otherwise nearly impossible to scale it and to do it objectively. Okay. So this came to our first R01 through our lab, and it was a multi-institutional study with Cedars, MD Anderson, Houston Methodist, Rochester, and City of Hope. And we had Caltech as our hub for all the deep learning models that we did. And this was our vision. We published this in JAMA Surgery, really as a vision before it was all done. But we wanted to take surgical video. We wanted to use the video itself to train a deep learning model to produce a granular assessment, uh, essentially a report card for granular suturing skills. And we intentionally wanted it to be granular because we deep learning models are otherwise known to be black boxes, but here we wanted to provide that granularity to the receiving surgeon so that he or she can certainly improve their performance and know exactly what they need to work on. And once you have that profile of the surgeon's performance, we wanted to train yet another model to predict patient outcomes. This could be anastomotic urine leak, it could be the continence recovery, and so forth. Okay, so we are in the final year of this grant, and we've published three fantastic papers in the Nature portfolio journals. The the main paper was that we have a surgical AI system that can parse through video and provide a skill assessment. And I'll go into a little bit more detail on each of these projects. But if you're going to judge the quality of the surgeon, you better be sure that our assessments are fair across different cohorts of surgeons. And then finally, we wanted a paper trail or some way of explaining how we arrived at these assessments. So this was our center piece paper that was published in Nature Biomedical Engineering. Here it's featured on its cover. And this is a busy slide, but it illustrates the point that at the very top you have the surgical video. So video is essentially frames over time. And in the top left, you see the changes of pixels. These are the RGB pixels. How are they changing simply over time, each little tiny pixel? But there's also something called optical flow maps that we are able to create, which largely is tracking what's moving from frame to frame. And in most instances, it is the instrument as well as the needle, particularly for a suturing task, that's moving. And so now we are able to estimate movement, directionality, magnitude, that sort of thing. And it's this information that we are tracking over time, spatially and over time, that we are distilling down to, at the very bottom here, verdicts of a thumbs up or thumbs down in terms of each of those granular suturing skills. And so we are able to train these models with labeling from our trained human raters of what is considered thumbs up and what's thumbs down, ideal or non-ideal examples of each of these suturing skills. So at some point, we trained the models to be about 80% accurate, and we were very excited about that. And we thought, hey, job well done. But when we looked at it a bit in more detail, we found that the model was performing unevenly, meaning that for some cohorts of surgeons, it was performing more accurately, and for others, it wasn't as accurate. Here, the example is more experienced surgeons. When their videos went through our assessment, they were less accurate. The less experienced surgeons, their performances were more accurately rated compared to ground truth evaluations. There are ways of mitigating this bias, what we call algorithmic bias, and in doing so, the model performance will improve. And one of our approaches to improving or reducing that bias was actually led to our third paper, which is on explainability. So if you ask human raters, in a string of 1,200 video frames, where they are looking in these frames of video to assess needle handling, this is when the surgeon is passing the needle back and forth between his or her graspers to get that needle in its ideal position for driving. The human raters don't have to look at every single frame of video. In fact, in this instance, they have to look at the very beginning of the series and at the very end, because that's where needle handling occurred. And we can do the same with the AI models. We can ask the models, hey, where are you looking to make your assessment? And as you see here, it agreed with the human raters that at the very beginning and at the very end, that they're looking for needle handling there because that's where they're assessing quality of needle handling. But there's also this area in the middle where it's probably needle driving, maybe cinching of the suture and so forth, where there's absolutely no needle handling occurring, yet the model was looking there erroneously. So we're able to retrain the model to behave more like the human and look in the same places at the humans. And in doing so, of course, the models perform more accurately, but that bias that we saw in the prior project also was mitigated to some degree. Okay. This is simply to show the practical aspects of deploying these assessments in live training. So this was last summer, we trained about 20 junior residents. This is both general surgery and urology because we needed the numbers to perform the vesical urethral anastomosis. This was in our lab. This is our mock-up version. And it was a randomized controlled trial, so we had folks who were in the control where they only got the ideal reference video of how it should be done because many had never even seen a vesical urethral anastomosis. We had a conventional group where they got to watch their own videos in addition, and also have the scoring rubric to which they were going to be scored against. And then finally, we had a tailored feedback group where not only did they get everything that the conventional group got, but they also got a sense of exactly what were the skills they were failing at and how to correct their behavior. So they weren't given everything, in terms of their scores, but only for areas where they were failing, they were getting corrective intervention. Again, this is an example of our scoring criteria. These are 7 of the skill domains with what was passing criteria. And what we found was, so there were 6, 6, and 7 allocated to each of the groups. This is what the end product looks like. It's a simplified anastomosis. I think we had 8 stitches on both urethra and bladder side, just for timing's sake. Although a typical live VUA is about 12 plus 12 stitches. Here is a great example of a dog ear that we never want to see and probably contributes to water leakness. So every single one of these were tested for water tightness. And what we found was that in the control group, nearly nobody achieved water tightness by the end of the 10-week study. So there was 1 VUA per week, not much difference for the conventional group. But look at the tailored group. Again, these are the folks who got the focused or tailored feedback on what they really needed to work on in terms of those technical skills. And by week 8, every single one, 7 out of 7, of the participants in this arm had a watertight anastomosis. What I didn't show here is we also did a 11th session that was a month later, where there was no programmed feedback, and certainly a session where they did not receive any additional feedback. And in the Taylor group, 7 out of 7 of the folks there had a watertight anastomosis, whereas in the other 2 groups, I think 1 out of 6 in each control and also conventional achieved a truly watertight anastomosis. So this is, we're keen on deploying some of the work that we've done into the training space, and we see that this is a dramatic impact to that work. Okay. Again, now we can also predict what are the skills that were contributing to this water tightness. And these were the top 4 suturing skills that allowed our predictive model to correctly anticipate whether it was going to be a watertight anastomosis or not. Surprisingly, cinching, which I thought would be extremely important, was ranked number 8. But that's just my side commentary there. Okay, let's talk about surgical gestures. This is yet another approach to sizing up the quality of surgery. This is entirely different. This leads to our second R01, and this is using deep learning models to assess the quality of tissue dissection. And we thought there's no better test case than the nerve-sparing step of the prostatectomy. So as many of you know, this is a procedure that we have been doing for literally decades, and the outcomes are that 20 to 50% of patients recover sexual function the year after surgery. Now, and this is another multi-institutional study, including ourselves, Cornell, Stanford, MSK, and City of Hope, meaning that these are all sites that have contributed data to our analyses. At the centerpiece of our approach here has been, for tissue dissection at least, is labeling the data with surgical gestures. And I'll explain what that means. But surgical gestures, in effect, is the most elemental part of surgery, at least in terms of tissue dissection. We created this classification system where dissection can be either a single blunt maneuver, or it could be a single sharp maneuver, or there could be a combination of different gestures put together. Here are some illustrative examples. So this is the curved scissors just spreading its jaws and spreading tissue. That is considered one single gesture. This is what we call a peel push against tissue to open up natural tissue planes. We call this the hook. And for sharp dissection, this is a single cold cut. This is an energy cut. And this is burn dissect, where that previously hooked tissue is now you're applying energy as you're pulling it towards you. This is pedicalizing, so you're opening up a window. This is called two-hand spread, and this is coagulate, then cut. Okay, so you get the idea. So now what you can do is you can take a surgical video and decode it into a sequence of surgery, similar to the genomic code, where you have now a spread, hook, burn, peel. So back to the prostatectomy, the nerve spare step of the prostatectomy. What we can now do is we can sequence out an entire procedure. These are the first 100 gestures for the nerve spare step of the prostatectomy. And the average step takes about anywhere between 200 and 400 gestures, depending on the surgeon and perhaps the patient. So these 22 rows that you see here, they represent 22 different patients who have undergone the nerve spare step of the prostatectomy. And what's common about them is while they all had sexual function for sexual intercourse, they do not recover function 1 year later. In contrast, these are 18 additional patients, 18 folks who had function before surgery and do recover function afterwards. So if you apply statistical, your traditional statistical methods of identifying who were going to be the ones that recover function or not, to some degree, energy use, as we showed in our recent JAMA surgery paper from about 3 months ago, is a predictor. However, it's not, it's not as robust as what we've discovered, where if you plug these whole sequences of gestures into what we call sequential models, they're specialized AI models that have the memory of one gesture to the next, to the next, to the next. So they have rolling windows of up to 35, 40 frames. We can now predict with an approximately 85% accuracy whether these patients will recover function or not. And this was, to me, a huge milestone because, again, this is a procedure we've been doing for decades. We've never been we've taught this procedure by dogma. I've done it a certain way because my mentor taught it to me that particular way during fellowship, and he learned from his mentor. And so it's just been passed on by dogma and not by data. And so this truly has been one where we're demonstrating that taking data, again, on the day of surgery to predict an outcome that is, a year away is truly fantastic. Okay, but predicting a good outcome is not good enough. What we aspire to do, so I've shown you the state of the art. Our aspiration is for patients who do recover function, we want to study their sequence of gestures and understand, and our models, again, similar to the feature ranking I showed you earlier, it can do something similar here, where it can identify very specific clusters of gestures that were particularly helpful in the model's ability to predict that good outcome. And in contrast, for someone who does not recover function, we want to see, well, what were the gestures that put that patient at risk for not recovering. And so far, our best understanding of all of this is that it's not a singular movement that's deterministic, meaning that, I had expected this giant scissor to come and just cut the base of a nerve or something like that. And we don't see something as dramatic as that. But there are clues throughout an operation that, this is why this patient likely will not recover function a year later. So this is where we're at. This is ground zero for us. Okay. This is simply to demonstrate that as we have worked in the last 5 years in the space of surgical gestures, by adding more information and more useful information, particularly those that provide more context to these gestures. What are the gestures as a group doing? Similar to the alphabet, you have different letters of the alphabet, but you also have words that have meaning, that string different letters of the alphabet together that have a unique meaning. So we've done that. We've also looked at the anatomical locations of these different gestures, and this is where we get to our AUC of 85. Okay. This is a paper that's essentially under review, but again, it's what I just mentioned, taking common gesture pairs. You go from a cold cut to a spread. This is, to achieve the function of releasing the neurovascular bundle off the prostate, and this is located in the lateral prostatic fascia. This is seen over 4 times more in patients that do have recovery compared to those who do not. Okay. And that, again, these are just examples of how we are applying, we're zeroing in on very specific actions, but it's not just a one-time occurrence, but this is multiple times over not just a single case, but many hundreds of cases that we are then able to say, hey, I think we're onto something here. And as I mentioned earlier, machine learning, as much as it is wonderful, it is still identifying associations. It is not proving cause and effect. We would love to get to that point where we can do cause and effect. I've had a lot, Andrew Vickers is our statistician from MSK. He is our study statistician for this R01, and it's always a challenge. If we can convince him of something, I think we can convince the world, honestly. So this is a space where we're really keen on working towards a point where we can deliver actionable feedback back to a surgeon. And so this is where we're at in all of this. This is that JAMA surgery paper, our most recent publication. Again, this is the multi-institutional paper coming from 5 different sites. We've looked at 28 different surgeons performing the prostatectomy. And these are sites from Gronau, Germany, Stanford, MSK. It has Vip Patel's series in there as well, and Cornell with Jim Hu. And this was our first paper where we've put together not only the gesturing, but also the technical skills for tissue dissection. We call it DART, but it's similar to the suturing metric, where we're looking at respect for tissue pain, how the surgeon is handling the tissue retraction. This is all during the nerve spare step, again, of the prostatectomy. And the goal in this particular study was, again, to predict that 12-month sexual function recovery. So we found that recovery was associated with greater proportions of blunt dissection gestures, that peel push that we explained earlier, lower use of energy gestures, and then also what we called a adverse event when the surgeons actually grab the neurovascular bundle that was associated with non-recovery. And those are on the gesturing side, but from a dissection technical skill standpoint, higher tissue handling scores were associated with better recovery. What is not mentioned here, because I thought it was a little bit controversial, was while the gesture usage and the technical skill scores were predictive of outcome, the experience of the surgeon was not. Granted, this was a series of probably higher volume surgeons across these different sites, but whereas we could parse out the prediction part, 35% of patients recovered function in this series. And these assessments were predictive of outcome. Uh, Surgeon performance was not. This is another usage of AI. This is through having a breakthrough of image segmentation through SAM or segment anything. This is was published in the literature in the last 2-3 years, and it's really revolutionized how we can automatically segment or identify areas of interest. This could be applied to pathology, radiology, and certainly in our field of surgical data science, where now we can look at if a surgeon is using their grasper to grab the neurovascular bundle, which they probably shouldn't be doing at all, but identifying how much tissue they have grabbed and then relating that to whether these patients recover function 12 months later. This is very preliminary work and a very small data set, but the trends are, it looks like they are related. This is, again, with that same situation where now they're retracting the neurovascular bundle. The more angular deviation of that leading edge of the bundle, it looks like it may be related to non-recovery. And then also when you stretch the neurovascular bundle, you're going to increase that surface area. And so looking at the percentage of percent area change of the bundle and then relating it to outcomes, I think we're onto something here as well. Okay, finally, I know, hopefully we can save just a few minutes for Q&A, but we've spent the last decade on assessing the quality of surgery. And at some point, that journey is going to be ongoing, but at some point we thought it would be appropriate to think about how would we design the vehicle of delivering that assessment back to the surgeon so that ideally you can complete the loop and change uh, behavior, but also improve outcomes. And that leads to our most contemporary project. This is one that we have partnered with UC San Diego, Stanford, and NYU in assessing, optimizing, and delivering surgical feedback. And the feedback we're thinking about is in the operating room, live surgical feedback. This is the mentorship between a trainer and a trainee. This is the foundational work for what we have proposed. This is about 30 teaching cases where we decoded about 3,700 lines of feedback. This is between the trainer and trainee. So each line of feedback has a trigger. So we created this classification system for that dialogue between trainer and trainee. It's obviously very complex, so we overly simplified it to having a trigger. So the resident or fellow did something wrong, or they didn't do something they were supposed to do. There's the feedback itself. Most feedback is verbal, and most of it is about technical skills. Do something differently, retract more, turn your wrist more as you throw that stitch. It could be about the procedure, what to do next, or something about the anatomy. Hey, watch out for the ureter. You see it, right there in the corner of your screen. There's also sometimes visual aid, and from a stylistic standpoint, there could be praise or criticism laced in the feedback itself. And then finally, there's different outcomes that can result in all of this. In the best case scenario, we want feedback. We want feedback where that the trainee will, at the minimum, acknowledge that they understood the feedback, or even better, they change their behavior as a result of the feedback. This is a illustrative example from the series where we looked at similar feedback on on anatomy. But if you sprinkle, this is for our faculty on this call, but if you just sprinkle your feedback with just a little ounce of praise, that statistically increases the odds that your resident will change their behavior or at least acknowledge they understood what you're talking about. Okay, so in that pilot study, we had 30 cases, and that translated to those 3,700 lines of feedback. The goals of this grant are really to identify the patterns of ideal live surgical feedback, the most impactful feedback, for whether it's the content, it's the style, it's the language, all of that. And And from the 4 partner sites, we anticipate collecting about 500 lines of feedback. So that will amount to, at the same rate, about 85,000 lines of feedback. So whereas the prior paper that I just shared with you was done with human annotations for everything, human transcription and annotation, it nearly broke the backs of the folks doing the work. And with 85,000 lines of feedback, that's just simply impossible. So we just published this last year in Nature Digital Medicine, where we have now created a whole pipeline of being able to process that volume of information, starting with the video and the audio. So in each of our partner sites, including Cedars, every resident and faculty are wearing a Bluetooth microphone. So we are recording the language. We're doing auto transcription of that into transcripts, and what we've done here is what we call unsupervised learning, where you take all these transcripts and you throw it into a model that, without labeling, can put ones or cluster ones that sound similar to each other into the same bucket. And then what we've done is we've, in kind of reverse order, taken everything in that bucket, all these transcripts of supposedly minded or similar ideas, and we've sent them to ChatGPT to give us labels. So these labels, it's the labels themselves that came from ChatGPT. And you see here one, with the red dots. This is the one that was labeled as handling bleeding, and as a sanity check, we hope that everything here, if the trainer said something about handling bleeding, the hope is that the trainee will actually act on it and change their behavior, take care of the bleeding, for instance. And in fact, that is true. We see that happening. So if you can imagine, this a similar pipeline where we take the video, audio from all these brand new cases, they can get sorted into the right buckets. And more importantly, we also have prediction models looking at the video part of it to identify whether or not behavioral change was happened, and maybe even skills have improved from, let's say, a low skill example to a high skill example. So then we're also leveraging some of our technology from the other 2 grants on assessment into this whole pipeline. These are word clouds, simply, just to show, like, these are the real world examples of, again, in that second bucket of controlling and addressing bleeding. These are the remarks that the trainer is actually saying. And finally, this is the full workflow that we have published in ML for Health. This is a health AI conference. I'm going to play the audio. Okay, so for the sake of time, I mean, you hear my voice, you hear one of our chief residents, and from that, we have active models that can identify when speaking actually is occurring. And not only that, it will detect that there are 2 distinct voices and will assign them as speaker 1 and speaker 2. It is up to us with samples to identify who speaker 1 is, in terms of each surgeon has a anonymized identifier, unique identifier, I should say. Then there's the automated transcription. And this is also where we do the assignments of trainer versus trainee voices. And then the clinical task is, identifying the feedback itself. What is it about the feedback? Was it effective? Was it something about anatomy, procedure, or technique, or a combination of all of that? All right. Just to save a few minutes for our Q&A, the take-home points are: I've shared with you different approaches that we've used AI to assess the quality of surgery, whether through the instrument tracking, technical skills, the building blocks of surgery, using surgical gestures. But I hope you've noticed that in every one of these instances, we have used the patient outcome, so whatever that patient outcome, as the real ground truth. That's ultimately how the surgeon performed. and that is the ultimate surgeon performance metric. And I also shared with you our most recent work on optimizing the surgical feedback so that hopefully we can complete the loop and move towards a day where we can really change and improve patient outcomes. This is just a few members of our team. We have a hybrid AI and clinical team that works together and doing the fantastic work. And again, thank you so much for the opportunity to share our last 10 plus years.